You're listening to the Assembly on Pulmonary Rehabilitation podcast, brought to you by the American Thoracic Society.
Welcome everyone to another series of our podcasts. My name is Professor Clarice Tang. I'm a professor of physiotherapy at Victoria University in Melbourne. Joining me today is Dr. Filipa Machado from University of Porto at Portugal. Hi Filipa, how are you?
Hello, thank you for having me.
Thank you very much, Filipa, for joining us today. We're going to discuss a very important topic entitled the use of field walking tests in pulmonary rehab. So I guess just begin with, I would love to actually get a more understanding about your perspective of why we should actually be thinking about doing field walking tests in pulmonary rehab.
Well, we have three field walking tests that we commonly talk about: the 6-minute walk test, the incremental shuttle walk test, and the endurance shuttle walk test. And if we look into the different statements and guidelines about PR, it's there always written that is essential. It's really a core essential assessment that we do a field-based test. Because we need to, first of all, prescribe exercise. That's a core component of the PR programs. And so these tests help us with exercise prescription and tailoring the exercise to each of our patients' capacity. Then we also need to understand a bit of their prognosis. And these tests also can inform us on prognosis, survival. And also we need to assess our PR program, and with these tests we can have a pre-assessment and a post-assessment, and we can understand if the improvement was clinical relevant. So actually having a exercise assessment it's really essential. We have a gold standard with the CPET, the cardiopulmonary exercise test, but that's not something that is easily available to everyone. It's an expensive test that requires very well-trained staff. And these field-based walking tests are just available for everyone. So it's really the best we can do.
Fantastic, Filipa. I mean, for everyone, we know that the three most common field walking tests are the 6-minute walk test, the incremental shuttle walk test, and the endurance incremental shuttle walk test. Can you tell us a little bit more about what clinicians or health professionals should think about when they are choosing one test over the other?
Yes, so our choice falls mostly between two, the 6-minute walk test and the incremental shuttle walk test, because actually to perform an endurance shuttle walk test, you have to before perform an incremental shuttle walk test. So I would say we need to choose mostly between these two. And actually in the literature, we can find a lot of literature both on the 6 minutes and in the incremental shuttle. And you don't really find anything saying do this test instead of the other test. It's mostly about how much space do you have available, which tests are you or your staff trained on doing. And I think those are the main things. So the 6 minutes requires a quiet corridor of at least 30 meters. This is quite a long corridor. So sometimes you might have a shorter corridor and go for the incremental instead, because that one takes a 10 meters corridor. But then on the other side, with the incremental, you need to pay for the test. So there is a cost related with the sounds, the beeps that you need to use. And the 6 minutes is totally free. They both have learning effects. So I would say as long as your staff is trained on one of the tests, just choose that one. If you have enough space, just do that one. Then another thing you might have in consideration is the fact that the incremental and the endurance shuttle walk tests, because they have audio, so a sound to pace the tests. Some people older people especially, might have some hearing impairments and struggle a bit with keeping up with the audio. So that might be something you also have in consideration. And with the 6 minutes, you need to really know well the standard encouragements. So I think these are the topics to consider, let's say.
Fantastic, Filipa. I guess if you could share with us a little bit more, and you have actually done so, around some of the common pitfalls that you see with people when they are performing the 6-minute walk test to begin with.
I think the first thing that is common, and it's common to all the tests, is related with how our patients come for the assessment, because we tell them that they need to come in comfortable clothes and comfortable shoes, but before starting PR, most of the time they don't really know what PR is. They don't understand what they are going to be doing, and they might bring something that is comfortable for day to day, but that maybe is not so comfortable when we are talking about exercising or doing a walking test. So sometimes we struggle a bit with that. Then specifically for the 6 minutes, I would say this is a test with a learning effect, same for the incremental shuttle. So you really need to perform 2 tests at baseline assessment, and you need at least 30 minutes break between these 2 tests. And this might be one of the mistakes, that people don't perform 2 tests at baseline or don't give enough time for patients to recover before doing the second test. Another one is indeed related with the standard encouragements. So this is very standardized and has specific times to do it, so every minute. And if people don't follow the guideline, we can also have a bias in the tests related with that. And then it's very important to also make sure we repeat the conditions. So, for example, if the patient needs supplemental oxygen or if the patient needs a walking aid, it's important that we repeat the test in the same conditions after PR to have accurate assessments. And that might be also one of the problems. But I would say the main thing is really having a 30-minute, at least 30 meters corridor that is quiet, so without people crossing the patient, which would influence their walking speed and distance, and doing the encouragement really by the book, according to the rules, without other different words there.
Thanks, Filipa. And what about the incremental shuttle walk test? What are some of the common pitfalls? I think you've mentioned something about the need for audio recording, and perhaps people can't really hear the audio recording, especially if they're a bit impaired with their hearing. But any other common pitfalls that you encounter with the incremental shuttle walk test?
Yeah, so the incremental, same as 6 minutes, also has learning effect. So you need to test at baseline. So that's one of the things. If people actually do 2 tests and give enough time, again, at least 30 minutes for recovering. So that's the first thing. The audio, indeed, it's a bit difficult because, of course, the hearing impairment and maybe noise in the hospital or so, but also because it's an incremental test. So the pace is always changing. And people need to be able to adjust to this changing pace. And the staff conducting the test also needs to know the rules. If they are not being able to adjust to the pace, you need to stop the test. And sometimes it's a bit difficult because you need to give them just a bit of time to adjust. And if they pass that time, then it's to stop. But you often feel like they are just not being able to adjust, but not because they don't have the capacity. So sometimes it's a bit difficult. But the learning effect, so the 2 tests helps with that. Maybe they struggle a bit more adjusting in the first test because they are also understanding the audio, the pace. And in second one, maybe that will go better. And related with this, then I think another difficulty is in case you are going to do the endurance test after the incremental one, right? Because the endurance requires the incremental one prior to it. But then you need to choose a percentage for your endurance test. So you can do 70 to 85% of the incremental, but okay, I can choose 70, 80, 85, something in between. And sometimes it's a bit difficult to know exactly what to choose. But most important is that you just choose the same when you do the reassessment, right?
Fantastic, Filipa. Thanks for sharing the common pitfalls. I guess one of the things that I'm really interested to get your opinion on will be the current ever-changing landscape in pulmonary rehab, where we are getting more different pulmonary rehab occurring in across more a wide range of different settings, in particularly via tele rehabilitation. So I'm interested to know from your opinion what kind of field walking tests or what are some of the adaptations that you know have seen regarding these field walking tests that people should consider when implementing the walking tests in different settings, such as the home setting or in a community or home environment?
Well, that's a really good question. And reality is I don't have a short answer because we don't have, let's say, enough evidence to say do A instead of everything else. So what I can share with you is I think it really depends on the setting. For example, on a community setting, you normally will have enough space for a field walking test. So for sure, then I don't see a reason why we wouldn't do a field walking test, considering this is the best we have. It's so well established. So either it's a community-based or, for example, telerehabilitation related to a community base that sometimes happens. So, for example, you have a center-based specialized PR program and you have that specialized staff. And sometimes you have telerehabilitation. They are connected via telerehabilitation to community-based programs. Can be on primary care, can be on sports facilities and so on. And there you don't have specialized staff and they are connected by telerehabilitation. So the specialized staff is helping and supporting the non-specialized staff on those programs at distance. I think there it's perfect to do a field walking test. You have enough space. It's something you can easily explain to this staff how to do. And I would say there is not much discussion there. Then when we move to actually home settings or telerehabilitation with people doing rehabilitation at homes, either home-based or via telerehabilitation, it's another question because most often we don't have enough space, right? We won't have a 10 or 30 meters corridor. So the shortest would be the incremental with 10 meters, but even that is too much. And in that case, we have some entities are still recommend to do an initial face-to-face assessment before you do this telerehabilitation at home. But the reality is that in a lot of countries, this is not feasible. We are moving to home-based and telerehabilitation because the distances are so big. And we need to find a way of assessing patients away from the centers, right? So in those cases, I think what we see in the literature is the sit-to-stand tests and step tests emerging as an alternative. So different tests, but with the same end goal, let's say. The problem for now is that we have a bit more literature on the sit-to-stand tests. And with these tests, especially with 1 minute sit-to-stand, we have seen it's possible to do it via telerehabilitation, for example. It's also possible to do it at home. We have some cutoffs for prognostic values with these tests. We do have minimal clinical important differences, so a response to PR, but we cannot prescribe exercise based on this test. At least no one showed yet a way of prescribing exercise with this. So we have a limitation there. And we talked in the beginning that one of our aims with these tests, one of the 3 aims, was indeed the exercise prescription. So although we can understand based on the result in 1 minute sit-to-stand if the patient is more limited or less, we can't prescribe. And the step tests that have also come in the literature, maybe a bit more recent in terms of telerehabilitation and home base, they have also showed potential. Both the modified incremental step test and the Chester step test have already been applied remotely successfully. And with this, we can actually prescribe exercise. If we prescribe step training, for example, which at home and via telerehabilitation would be very feasible, we can do a direct prescription. We have a bit less evidence with these step tests yet, of course. We have some minimal clinical important difference, some cutoffs, not so many and so well established as with the 1 minute, but we do have some evidence on that. So I would say maybe the step test will be our alternative for exercise prescription, assessing PR program, and having some prognosis idea in these telerehabilitation and home settings, because indeed we can prescribe exercise. That's how I see the potential of this, at least for now.
Thanks, Filipa, for that very insightful response. I guess this is the last question for the podcast, but I was wondering whether you could summarize like 3 key take-home points that you would like everyone to consider when conducting these common field walking tests.
Yes, so I think the first point is, of course, that assessing this exercise capacity is really key for our patients. So please, everyone, use at least either 6 minutes or the incremental. Keep these tests in mind. These are great measures. Don't forget to use them. And also don't forget that they have a learning effect. So we need to do 2 tests at baseline, please. Then I think another important message is that we are moving forwards, indeed, in the PR programs, and we are finding alternative PR programs. So we might need alternative ways of prescribing exercise and alternative tests to the field walking tests. Probably something like the step tests will be something we'll be doing in the future. But while we don't know and we are not sure about the best option, for sure, field walking tests are still here for us. Keep them in mind, especially if you have enough space, if it's community, a sports facility, if it's easy to do an assessment like this near your patient home, just do it. Don't forget to assess. Second, don't forget the learning effect. And third, don't forget the alternative options, but still keep field walking tests in mind.
Thanks, Filipa. Thank you so much for sharing your pearls of wisdom in terms of what we need to consider when implementing our field walking tests. I hope everyone has enjoyed this podcast, and I'm looking forward to host the next episode. Thank you very much.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.